Thanks for joining us this evening. I'm delighted to welcome you all to this Refugee Week webinar and share this important and timely discussion with you. My name is Amaran. I'm a paediatric doctor and member of the ICHG advocacy group. For those perhaps a bit newer to ICHG, it's a specialty group of the Royal College of Paediatrics and Child Health that sits independently of the college, meaning that it can inform and impact the institution on issues we and its members understand to be important to global child health. Our group comprises paediatricians and child health professionals from the UK and around the world, brought together in the pursuit of global child health equity. The advocacy group currently organises through three streams. The proactive stream focuses on upskilling paediatricians with advocacy capabilities, as well as organisational capacity building. The second is the migration, displacement and child health stream, which is a topic-focused space geared towards the advocacy of child refugee and migrant health in the UK and abroad. Thirdly, our reactive stream works to respond meaningfully to new and emergent issues in global child health. More information on the advocacy group's activity and how to get involved will be covered towards the end of the session. The first part of the event, which includes our three short talks, will be recorded to share as a learning resource for those unable to attend tonight. The recording will stop for the discussion and Q&A, but be sure to check that your microphones are off during the talks. So we have a lot of discussion and insights from our speakers to get through this evening, but before then, I'll briefly start by expressing my gratitude to those who made this webinar possible. Thanks to the dedicated team that put this event together, Amy, Kerry and Daphne, our guest speakers who've given their time to share experiences and reflections, Regia, Alia and Chris. And thank you also to the wider ICHG paediatric and child health community who've engaged with and supported this work. At the centre of this evening's discussion are the children and young people who, through circumstances far beyond their control, have experienced immense hardships and systemic violence, both within the health system, through barriers to accessing care, healthcare charging and fears of reprisal, as well as outside of the health system through deeply harmful social and economic policies. This ecology of violence also absorbs the many thousands of children and young people displaced from their homes around the world, fleeing conflict, violence, persecution, and the impacts of the climate crisis, both in this very moment and in our past. A cursory glance at the discourses on migration in the last 7 days is a damning reminder that some lives appear more valuable than others. As we speak, millions of dollars worth of equipment, staff and resources are being mobilized by rescue services in the Atlantic for ultra-wealthy tourists that are sadly missing. Yet, as Professor Priyamvada Gopal says, but fleeing your life and desperate livelihood merits being left to drown in large numbers, as long as we are clear. It is with them in mind that we reflect on what we can do better as a community of child health workers, taking action in solidarity with their struggle, addressing these injustices. This evening also aims to develop an understanding of the impacts of the hostile environment policy suite, including NHS charging as one of the myriad impacts on refugee and migrant children. We're privileged to share a space alongside a family with lived experience to provide their testimony for health workers to bear witness. We're going to explore the state of play for policy and campaigning at a national and subnational level, highlighting practical examples for ways health professionals are harnessing their compassion, working in solidarity with and getting involved in addressing these aforementioned injustices. The discussion will also explore how we might envisage the evolution of the child health professional with regard to strategic grassroots and institutional advocacy, both in the UK and for our colleagues joining us from around the world. Our first speaker is Regia, mother of Omisha, who, when aged just 10 months old, was diagnosed with a rare form of liver cancer. The NHS saved her life. She needed a liver transplant and has undergone several rounds of chemotherapy. And although Omisha is thriving, as a result of hostile environment immigration policies, their local hospital, Barking, Redbridge and Havering NHS Trust, sent them a bill for £76,000. Regia will be sharing her account of the lived experience navigating this immense hardship and is speaking out to ensure that other families do not have to go through the same thing. Thank you, Regia.
Thank you very much, Amaran. So hello everybody, my name is Richa and I'm Omisa's mom. So I'm very grateful to be invited to speak on the International Child Healthcare Group online webinar and to share my experience on the hostile environment. So at the moment, together with migrant organized team and the Patient with Passport campaign, we are campaigning against the hostile environment for migrants and refugees and to end Omisha's NSS charges. So to begin with this speech, I'd like to give you a little background of our story to let you know when it all started. So in the year 2020, Omisha was diagnosed with a rare form of liver cancer when she was 10 months old. She had 6 cycles of chemotherapy to remove the tumor from the liver, but due to some complications, the surgeon suggested to perform a liver transplant surgery. So in 2021, she had a successful liver transplant surgery, and we are very thankful to the NHS healthcare staff who gave her new life and supported us in our difficult times. So the whole NHS charge started when we were transferred to our local hospital during her chemotherapy when they checked the immigration status of Umisha and of me and my husband. And at the time, we were awaiting our decision from the Home Office about our human rights case, which we had applied for in 2015. So while we were waiting for the decision, we were not allowed to work and we didn't have access to public funds during that period, which meant that we were not entitled to any support from the government or local authority. When they figured out our visa status, the overseas officer from our local hospital told us that Omisha would be charged for her treatment. This was on the Barking Havering and Redbridge NHS Trust. The other two hospitals where she had her chemotherapy and transplant chose a compassionate approach towards us and didn't charge us anything. However, with the local hospital, they chose the unfair system of NHS where immigrants patients are charged on the category of overseas visitors, no matter how many years they've spent in the UK and how much they contributed for the whole nation. So they began to send us the NHS bill, notice, email, calls, any form of communication possible for the payment, and later handed it over to the credit management team, which is a debt collecting agency, to recover the debt from us. We kept explaining our situation to them, that we were merely surviving with the support from charities, loans, and support from our friends and family. But they always refer us back to the NHS regulations, where they have to recover the debt to the overseas visitors. Later, with the support from migrant organizers, we sent them the letter of destitution with the evidence, with a lot of evidence of not being able to pay such a huge amount of money. Eventually, they agreed to put the debt on hold, but it took a huge amount of effort for them to believe us about our financial situation. This somewhat helped, and then Omisha was finally also granted British citizenship, which means that all her future treatments are now free of charge. But the hospital was still focusing on the regulations where it says they can recover the debt anytime when the destitution ends. So we opened a petition to end Omisa Charles and to end the hostile environment for the refugees and migrants with lots of campaigns, events, news articles in the local newspapers, and the independent promotion from the members of Justice for Omisha campaign helped the issue to reach to the CEO of BHRUG. And finally, we received the apology letter from the CEO, Mr. Matthew Trainer himself, for delaying the decision not to pursue the overall debt now and in the future. And he apologized to us for the stress that he has faced during the process. He also added in the apology letter that from now on, the trust will show a more compassionate approach towards the migrants who cannot afford to pay a huge sum of money for the treatments they receive. So this is a huge win for the campaign and for the refugees and migrants who prevent themselves from going to the hospital for the treatment and risk their life to avoid the NHS bill. So the main purpose of doing the campaign is not only to end my daughter's NHS charge, but to end the unfair system of NHS charging the immigrants and refugees, and also to bring the change in the NHS regulation itself, so that the overseas team wouldn't have to refer us back to the harsh NHS regulations. Please, I request everyone to continue to sign and share Omisa's petition because the debt is still recorded in the file of the Home Office and the NHS Trust cannot cancel it. Means to the Home Office will our demands in the petition is Right. You, yes, thank you for the host of the future, which will be able to end and refugee. Thank you very much.
Thank you, Rija. That was a very helpful and valuable perspective into the experiences of Omisha and your family. And despite that incredible hardship, at least there was some positive outcome, and I'm really grateful you were able to speak out about that.
Thanks.
There will be lots of questions, I'm sure, from the audience, but what we'll do is we'll get through the speakers and go in for a question and answer at the end. But thank you so much. Okay. So our second speaker is Alia Yul. Alia works as the Access to Healthcare Organizer at Migrants Organise, where she organises with migrants and refugees for dignity and justice. She works on the Patients Not Passports campaign to challenge border policies in the NHS and to guarantee free and accessible healthcare for all. Thank you, Alia.
It's the moment, the trepidation of is the share working? Everyone can see it, okay?
Share is working, it's all good.
Amazing. Thank you, Amaran. And thank you so much, Rija, for such a powerful account and your testimony of the reality of living under the hostile environment, this immigration system that several governments, successive governments have built. I'm Alia. I use she, her pronouns, and I work for a charity called Migrants Organise. We're based mostly in London, but we organise with migrants and migrant communities across the whole of the UK. For dignity and for justice, as Amaran said. We do that through direct support, immigration advice, English classes, building community activities, and then we organise with our members around the issues that are facing them in the here and now. And that means we take action on the things, the injustices that they face in their lives, and build power in our communities to overcome these things. And one of the sort of main things that we've seen over the last sort of 10, 15 years is a real increase in the number of people who are unable to or so scared to access healthcare, or who have received huge bills for doing so. And so I'm going to talk a little bit today about the Patients Not Passports campaign, about how we're fighting back against the system. But before that, I just wanted to very briefly talk through sort of what the hostile environment in the NHS actually is. The hostile environment, brief history for those of you who may not know, was officially introduced under the then Home Secretary Theresa May in around 2012 to 2014 with an Immigration Act, which essentially attempted to bring border controls into all of the vital public services that people need to leave. The stated purpose of these policies was to make life so unbearable, so undignified for migrants in this country that they would self-deport or choose not to come here, which demonstrates a woeful lack of understanding of the reason that people move in the first place. The hostile environment was a suite of policies. It officially was introduced in around 2014, but this isn't to suggest that the immigration and asylum systems were a bed of roses before that. The prior Labour government had introduced things like the no right to work policy, which means that if you're in the immigration system, an asylum seeker, or waiting for the outcome of your immigration application, you are denied the ability to work or to study. Sort of left in limbo for years on end. And then there was this introduction of things like the right to rent checks, which you may have heard of, where landlords now have to check people's immigration statuses before renting them a home. And that's led to incredibly discriminatory practices from landlords when, scanning through people and finding foreign sounding names and refusing to rent them a house on that basis. This stood alongside people not being able to open bank accounts if you don't have the right immigration status, not being able to access much of legal aid in order to get a lawyer and be able to challenge different legal decisions that were made, not being able to access public funds, no recourse to public funds, which many of you will have heard of, which means that you're not entitled to any kind of benefit, any benefits, any government support. You're not allowed to get married, you're not allowed to drive a car or have a driver's license under the hostile environment. And this system kind of sits together to have a really, really harsh impact. But one of the biggest targets of the hostile environment was the NHS and this right to access free, safe healthcare. Just before we go onto kind of the specifics of how it works in the NHS, I think it's important to think about like who is it that the policy impacts. Primarily, the stated target of the hostile environment was undocumented migrants. There are many, many reasons why people become undocumented in this country. Lots of those reasons are to do with the difficulty that it is to navigate the immigration system and asylum systems in and of themselves, the amount of evidence that you have to provide to the Home Office to prove your status, the cost of the immigration system, which has more than doubled as a result of the introduction of the immigration health surcharge, which we can talk about. So there are many, many reasons why people are undocumented. And the estimate is around 1 million people in Britain. And the Mayor of London recently did estimates of that there are around 200,000 children who are undocumented living in Britain, and about half of those live in London. But the hostile environment also impacts not just people without status, but people who are seeking asylum and have applications or have been granted refugee status or have been granted their leave to remain, their visas. Because this system requires that public services and other institutions ask people about their entitlements, ask them about their immigration status, it ends up impacting so many more people. Particularly asylum seekers are impacted, particularly as about half of all asylum applications which are refused on their first application are then granted at a later date, which means that many people will fall into the category of being undocumented because they're a refused asylum seeker, and so will become chargeable, as we'll talk about under the hostile environment in the NHS. But that is a fault of the system, and so you can see how people's immigration status can change overnight. Obviously, there are many people who have been settled here for many more years who have their immigration status sorted or have become British citizens, but the non-UK born population is about 14% of the population, and they are also impacted by these policies because of this need to check people's immigration status, to check people's entitlements, which means that anyone who is racialized or considered to be other is often ends up, as we've seen with the Windrush scandal, falling foul of the policies because they're expected to be able to demonstrate their entitlements to accessing services, and like with the Windrush scandal, where people were unable to do so, are then cut out of being able to access those services. Much of the hostile environment requires that you have some form of ID to prove your citizenship, your status. And in fact, 17% of people in this country don't have a passport. And so I actually would find it very, very difficult to do that. And so what we can see is that the hostile environment, although is sort of said to target a smaller group of people, has repercussions right across society. You may have seen these kind of posters up in A&E. These were taken somewhere in London, basically saying that NHS healthcare is not free for everybody, sort of creating this fear that, in fact, NHS care for many people is charged. The hostile environment in the NHS works in sort of four main ways. The primary way is through charging for secondary NHS care. Primary care and treatment is free. And the cost is set at up to 150% of the national tariff of the actual cost of care. And the real step change in the NHS was the introduction of upfront charging in 2017, where if your treatment is deemed not urgent or immediately necessary to save your life, you will be charged upfront, meaning if you don't have the ability to pay, you don't have the means to pay, you will be refused that care. Otherwise, you will be charged retrospectively, usually in the realm of thousands and thousands of pounds, depending on the treatment. The second kind of main way that this works is then checking people's status when accessing services. For a long time, there was a system of sort of ID checking of everybody, where you had to bring in two forms of ID to any appointment that you attended. Very quickly, for the reasons we stated, that many people don't have forms of ID, that pilot scheme was dropped, but still people are required to demonstrate their eligibility, usually by providing something like 6 months worth of bank statements or utility bills, and usually people have sort of 7 or 10 days to do so whilst they're in hospital. The other ways that this happens is through the third main kind of pillar of the hostile environment that actually intersects across much of the rest of the hostile environment, which is data sharing between government bodies and immigration enforcement. And so that NHS will share patient data with the Home Office, with immigration enforcement, particularly if you have an unpaid debt of over £500 for more than 3 months, that will automatically be sent onto the Home Office. But also we know that data is shared between the NHS and the Home Office when the overseas teams who are in charge of implementing the charging regulations in hospitals will call the Home Office. They have a hotline and say, here is the name of this person and their date of birth. Can you check them on your system? And inadvertently, much data, information is shared back and forth between the NHS and the Home Office. The final way that the hostile environment was introduced was the introduction of the immigration health surcharge, which is essentially an additional fee that you must pay on top of a visa application, which sits at £624 per person per year. Most people are applying for a visa for either 2.5 to 5 years, which, as you can see, quickly gets up to nearly £3,000, and that's for one person. You might be applying for your whole family, and so very quickly it becomes completely unmanageable. And it's a racist double tax, essentially, on migrants who are having to pay this fee in order to access the healthcare, on top of taxes that they'll pay for working like everybody else. I think it's important to note that there are exempt services, patient groups and conditions from the charging regulations. So primarily the charges target people who are undocumented, who don't have status. There are some exempt patient groups, including, as we mentioned, asylum seekers who have an open application with the Home Office. Some refused asylum seekers when they are receiving certain types of government support. People who are refugees who have been granted their refugee status. Children under the care of local authorities are exempt from charging, and survivors of trafficking are also exempt from charging. There are also, as we mentioned, exempt services. So primary care services, GP practices are all free for everybody, as is A&E. Family planning is also free, alongside things like health visiting, school nursing, which was actually initially chargeable, but then after some campaigning was won. And there are also things, certain conditions which are exempt from charge. So certain infectious diseases, like COVID, for example, is exempt from charging. And care given for treatment that or conditions that arise from particular forms of violence. Obviously, as you can see, it's quite difficult to prove that. People don't walk around with a sign that says torture, that I'm a victim of torture, a survivor of torture, on their head. What that requires is trust between you and your healthcare worker to disclose that has been the case. And what these policies do is engender fear and mistrust between patients and healthcare workers. I wanted to quickly just say that there is the immediately necessary and urgent care exemption, because I know that many people here are health workers, and it is a really important, we found, thing to know, that care that by a clinician, and it must be a clinician that deems care immediately necessary or urgent, must be treated before being charged for. But this means that many people will be able to actually access it, even if they don't have the means to pay. They will usually still get billed afterwards. And it's important to note, this is different from A&E. I'm happy to get more into this immediately necessary and urgent care, because it's a kind of finicky part of the regulations, but I think it is important to flag. We've talked about data sharing previously, but I think the thing I wanted to emphasize is the impact of these policies. Rija articulated so clearly the kind of stress that the policies have on families, on individuals who have been charged, being chased by debt collectors, usually for sums of money that they're unable to pay. These policies, are designed to inculcate fear in people so that they don't access healthcare when they need it, and people are deterred from getting the care that they need. And obviously what this often leads to is people delaying seeking treatment when they need it, delays when they are able to access services because of these checks for people's immigration status, and then also delays where people are simply refused the kind of treatment that they need because they are deemed to not have the right immigration status. It also is a practice that lends itself to racial profiling and discrimination. We see people, Black and brown folks who at A&E will get asked about their immigration status where that doesn't happen to their white counterparts. We've heard stories of overseas visitors teams going through bedboards of patients, identifying the foreign sounding names and targeting those people to ask about whether or not they're entitled to care. And ultimately, it puts people in a position where they're forced to choose between destitution and good health. And I think, there's really incredible work done by organizations like Maternity Action on the impact of this on maternity care, on the impact of that on the pregnant person's life and on the unborn child's life, where it has like devastating consequences. Evidence. There are many places where you can go to find research that has been done into the impact of the charging regulations. Some of them are here. There is a wonderful piece of research that was done by folks from the RCPCH in the BMJ about the impact on child health of the charging regulations. I really highly recommend reading that. What is to be done then under this system? What is wonderful is that there is a huge amount of opposition to the charging regime and to the hostile environment. The Academy of Medical Royal Colleges has called for the suspension of the policy. And of course, the RCPCH has put out a wonderful position statement calling for the abolition of all of the charging regime, and has also created a reporting tool where people can report instances where people have encountered the charging regime in some way, and it may have had an impact on their care and on their treatment. The BMA has passed several motions where members have voted to the position of the union should be to scrap the NHS charging regulations. And BMA has called for the suspension of the policy. We've been attending picket lines and doing teach outs about the charging regulations on picket lines in the last few weeks and over the last the strike actions, which has been a wonderful display of solidarity. And also members of Parliament have been speaking out about this for quite some time, particularly during the pandemic. There were 60 cross-party MPs who wrote to the government saying, that they could see the impact that the charging regulations would have during a pandemic, during a global health emergency, where people wouldn't be able to access the care that they needed, be that testing, be that the vaccine, be that treatment if they caught COVID. And so they called for the suspension of the policy during the pandemic. And there have been a number of other early day motions also challenging the regulations and the policy. But really, I want to talk to you today about the Patients Not Passports campaign. And I hope you can see this slide and all of these very wonderful and beautiful people who have been out basically since the introduction of the policy, campaigning against the charging regulations and against what is being seen as the NHS being turned into this new frontier of border controls. And what are we working towards as a national campaign? Well, ultimately, we want thousands of health workers right across the country, patients, communities, individuals opposing migrant charging and the hostile environment in the NHS. We advocate for improved access to healthcare, and we support people in our communities who are struggling to access the care that they need, or who are being denied it or refused it because of their immigration status. Ultimately, we think the way that we win is if we will get NHS trusts themselves and other health institutions to join us in opposing the policy, in recognising the harm that it's having on the patient communities that they serve and on their staff, by eroding the trust between patients and health workers, and fundamentally altering the principles on which the NHS was founded. We have this goal of moving towards mass non-compliance with the policy, which has been demonstrated successfully in places like Spain, where they had a similar set of policies that were introduced and thousands of healthcare workers simply refused to implement them. And that led to the repeal of the policies. Ultimately, what we want is an end to all charging in the NHS and to win a truly universal healthcare system accessible to everyone. How do we achieve these lofty aims? What we do is we build power locally so that NHS Trust join us. I am zooming in today from the launch of a new Patients Not Passports group that's being set up in Camden and Barnet in North London around the Royal Free Trust, where healthcare workers in the trust they're coming. Actually, one of them's just come into the room, but they have been organising to build support. They're just about to launch a petition. They're organising a film screening this evening to raise awareness in the local community about what the impact of charging is. And what this does is apply pressure, build awareness, and grow the support for the campaign. Really importantly, we organise with people who are at the sharpest edges of these policies. We work with people who have been charged for their care, been denied care, and we build community campaigns with them to speak out about what's happening. What we find is that the hostile environment is an incredibly invisibilizing tool. It's partly designed to marginalize sections of our communities, to make them invisible to us, and essentially to say that, you know, the injustices that they face are separate to us and should not be seen. And one of the things that we must do is build alliances, build connections across our communities in order to make visible what the hostile environment seeks to make invisible. And that's why making the impact visible is such a key part of the campaign, through research, investigations, FOIs, media coverage, and of course public events like this one. As I mentioned, we have many groups working on this issue across the country. And so if you see a place that you live in or work in and would like to be connected with them, I'll put my email address in the chat and you can, and I can connect you with them. But it's so heartening to see that communities right across the country are resisting this, building power locally, contributing to the national campaign, and ultimately trying to build a huge movement of people in opposition to the hostile environment. We have the Patients Not Passports toolkit, I think, which was sent around, and I can put it in the chat as well, which is designed to support you as healthcare workers in advocating for people facing charges, and also in how to take action. And it looks like this for now, but it's about to have a huge revamp, be updated, have a really clear guide for people who are facing charging, and what they can do, how to challenge it, and where they can get support. That is everything from me, and I'm sorry that I ran slightly over, but I hope that was useful. I'm really excited to hear questions, and thank you so much for having us here today for this really important event.
Thank you so much, Alia. That was such an insightful and valuable analysis of where we're at with regard to hostile environment policies. And yeah, delighted to see that there's so many health workers organising within their local communities, within their trusts, to try and oppose some of this. That's really positive. For all of us attending today, Alia has very kindly offered to share those slides with us for circulation, and they'll be part of the post-event resource pack that we'll be sending out tomorrow. So thank you again for that, Alia. Okay, we're just going to move on to our final guest. Our final speaker is Chris Harkinsey. Chris is a consultant paediatrician in the northeast of England, where he is developing an integrated child migrant health service. Chris has an interest in global health and has done extensive global child humanitarian work over the last few years. So thank you, Chris. And I've shared an article that was in the BMJ in reference to some of the topics that Chris will be talking about. Thank you.
Yeah, thank you, Amaran, for the invitation and for this introduction. No slides from me. It was all a little bit last minute, but I would like to share with you some of the experiences I had working frontline with child refugees and asylum seekers and their families. So it all started about 5 years ago, and it was more of a coincidence when I noticed that here in Gateshead, we saw a lot of people with a migrant background, refugees, asylum seekers attending A&E or attending other healthcare settings quite inappropriately and inefficiently, meaning they didn't meet the right expertise that could help them, or they had barriers to a degree that they were not really able to seek help in time. And a case that stuck with me was the one of a young child who had just arrived with his family from Jordan, who had epilepsy and then run out of medication, and the parents had no idea where to get medication from, and he ended up in PICU. And that made me think a bit more about situation of refugees and asylum seekers here, because I was more used to volunteering overseas in refugee camps and so forth. And by looking into it, I found that the issues are actually very, very similar here. What I notice is that these families find themselves highly excluded and at the same time very vulnerable. There were lots of barriers on one side from the people themselves coming, fresh to a new culture, not speaking the language, not understanding the system and how it works, but also a lot of barriers from the side of the healthcare system. One thing I learned quite quickly is that GPs often do not register these families, and even if they do, they would not be very proactive in actually assessing their needs and managing these or referring patients onto the right service. So they were largely excluded, although they do have, we just talked about charging and so forth, they do actually have a right and entitlement to the same healthcare than anybody else. Yeah? So there were these structural barriers, and I tried to then, find a way forward. How can we firstly find out what are actually the needs, and how can we get on top of the barriers? And it started then in a very informal way by creating or converting a general pediatric clinic with the agreement of my clinical director into a migrant clinic. And the access into that was through the TB nursing service. Essentially, I'm an infectious diseases pediatrician as well, and I see all the TB referrals. And we were notified through the TB service of families who come from a high-risk TB background. And there is a formal way of referring these patients into a TB clinic. So this was the pathway how we were able to see them, although I have to say, whilst we have a lot of support from our commissioners who have now commissioned the primary care arm of that service, the most resistance really came from managers in my own hospital who did not really like that informal setup. And I will come back to that, how we can move forward in developing better services and more formal services. What we did then, we monitored the health needs of people coming through this clinic. I can't really call it a service, but because it wasn't one, it was still very informal. And what was interesting is that we found the health needs to be very, very high. Most of the children and families came from war zones like Afghanistan, like Syria. About a third of them or more had psychological trauma and mental health and well-being issues. And 85% actually would fulfill referral criteria for a formal secondary care pediatric service. So essentially conditions like asthma that is difficult to control, malnutrition, chronic diseases that are poorly managed. 85% of all children would actually qualify for that. So I found that quite astonishing, and made me think that there is really a role for pediatrics and for secondary care in assessing and managing these patients, and we just can't leave it all to primary care. And this is where my idea came up to have something like an integrated service, because I saw quite quickly this can only really work if we work closely together with primary care. So a practice in Gateshead came actually to me and said, we are very interested in this work, and we are based in, our refugee and asylum seeker hotspot of Gateshead, and they had already a lot of experience with service for this population. So we started a formal clinic in that practice, where every other week there would be a full afternoon where we would give appointments to entire families for 1 or 2 hours, and we would do very comprehensive health assessments, very similar to what I did in the hospital. When I look at these families, and there was some comment already from the previous speakers, it is not just about focusing on an illness or a condition. What we need is really a very holistic approach, not just about health, but also about the non-health determining factors of health, which includes mental health, which includes social health and living conditions. And I found myself in the situation where I could make recommendations, but they would not be picked up. And then the health of children suffered. And that was often around housing, that is often around access to education. We have larger numbers coming through now, and schools are actually getting to their limit, and children, can't be put into schools. And I found that access to education, access to school is one of the key social aspects that actually stabilizes mental health, promotes integration. The children make friends, the children learn the language very quickly. The parents make connections to the local community, and that breaks through the barriers of isolation, and they build a support network which they otherwise wouldn't have. And that is one of my recommendations for anyone who wants to start that work, to look at that and make connections with a local education system and see what can be done, and raise the awareness and try to get refugee and asylum seeker children into school quickly. It is not just the benefit for their own education, it has a huge impact on the rest of the family. I try to have an intergenerational and life cycle perspective, and that stems a bit from my global health background and experiences I had in developing countries, where I observed if a child in the first 2 or 3 years of life, for example, suffers from malnutrition, it is something that will affect them lifelong with regards to their physical development, susceptibility to infection, but also cognitive development, educational achievement, and in the end, their ability to have a good quality of life, to earn money, to support their economy and environment as well. And likewise, if pregnant women or even adolescent girls, for example, already suffer from iron deficiency anemia, which is not managed, or other health conditions or other macronutrient deficiencies, that will have, again, a detrimental impact on their unborn child, with lifelong consequences as well. So this is why I think this family and life cycle approach is important. One good angle that helps to raise awareness is focusing on the health inequalities that this population suffers. There's a lot of drive now with many commissioners to tackle health inequalities. And if you look at the Core 20+5 agenda, asylum seekers and refugees are actually particularly highlighted as one of the most disadvantaged groups in our country. And making a good proposal to a local commissioner could actually use that perspective and generate some interest, in particular if you live in an area where there are lots of asylum seekers and refugees. So one of the questions was about, how to get involved. There will be time to answer that more. But what I would say is look at the Royal College of Pediatrics guidance that is on their website. That was only recently updated last year and gives you a lot of guidance about what questions to ask, the trauma-conscious approach, what investigations to do, what follow-up, and so forth. Raise awareness within your hospital and in your community. What I found was very rewarding that there were lots of organizations, colleagues at work, voluntary sector, partners at the council who were very supportive and very interested in this work. And if you can build a network, that will actually not only help you to manage patients, but also to raise the profile of this work. I was actually quite astonished to read the other day in The Guardian that the UK is in Europe the second highest welcoming country for refugees from the attitude of the population, only after Spain. But sadly, we heard about the hostile environment policies, which really, I think, blight us and blight migrants. So I don't want to talk much about charging. It's probably just to add, and I'm coming to an end in a moment, that there is a place for local advocacy. I raised that in my trust as well, and I got them to agree that we would do a review of the policy that we have and a review of the practices. And that is based on the report that came out of the Lewisham and Greenwich case, which again was in the news maybe 2 or 3 years back, where patients came to harm. It was in particular a maternity case. When that organization used a very similar approach to what we heard from Rija before, just trying to push to collect the money, sending some doubtful debt collectors around, not being willing to reconciliate or consider other options, and then resulting in someone not seeking help when they actually should have sought help, and resulting in a detrimental outcome. There is a very big report about that with recommendations and what they put in place, which I think is a very good starting point if you talk to your own trust and say, look, this is what another trust has learned from it. Can we use that as a template to make a start? Yeah, I see it as a start. It's still within that framework of that hostile policy, but trying to really minimize the harm coming from that. So that would be my recommendation with regards to charging. Another very interesting development I learned about only recently is that there is now a first ICS of sanctuary. You might all be aware of the cities of sanctuary. In West Yorkshire, the ICS there has now fully integrated kind of migrant support into their health system at all levels. And they are the first in the UK to actually being recognized and approved as that. Good, I think I stop here.
Thank you so much, Chris. That was incredibly useful to hear not only about your experiences and the case studies you brought, but also a rich variety of different positive cases as well, and different ways of ways that we can organise and move forward. So thank you so much for that. An article's been shared in the chat going into a bit more detail about your child refugee and migrant clinic service that you've been able to develop up in the Northeast. And there are some other very useful comments in there as well that Amy is sharing, so thank you. We're doing quite well for time. We've got about 20 minutes for discussions and Q&A. I have just a small handful of questions for our three speakers. And once we get through those, I'd love to open the floor up to questions from all of our guests here today. So to start off, it's a question for Rija. And you mentioned that the support from Migrants Organised was so important for you and Omisha and your family to be able to challenge the trust with respect to the charging of Omisha's care. Do you have any reflections to add regarding the input of the paediatricians involved in her care? Were there any positive or negative experiences that we might be able to learn from?
Thank you for the question, Amaran. So what we when we went to the hospital, like it's more about like when she had a chemotherapy and when she had a liver transplant, the doctors and surgeons were so supportive. Even during the surgery, they were like, no, because she in a very critical condition, she needed a transplant very quickly. So she was kept in the higher priority list, and she was called after 2 months for the surgery. So when we went to the hospital, it was very supportive and took care of us very well. So they are very good. But only with the local hospital, like because we were transferred to the local hospital because it was a pandemic time. There was a COVID going on in the house, so we live in a shared accommodation. So we were transferred basically because we want safe place for Omisha to have the chemotherapy. So we went there and we stayed for like 3 months, and during those period, like um, the overseas team from the local hospital were calling us for that you are staying there, so you need to pay for the charge. Sorry. So at that time, we were not aware that like there was a hostile environment going on, because we were just focusing on our like case, because we were dealing human with the home office. So we were not aware about the hostile environment time. So knew about the hostile environment going on, and we need to pay for the charge. Or like all the things came into like very depressing situation, because we're going through like so many stress already, and they are just calling every time to get us the money from us. So I think what we can learn is like to show a little bit compassion, like when we are already immigrants, and even we stay for like 10, 12 years, it doesn't matter for them, like they put us in a category for like overseas visitors, and they would like want to charge us money. So during those periods, like we were so hurt because we have done so much and we contributed here, we study here, and we have made like a family here, and we were thinking about like doing so much here, so much thing here. So we're getting calls, and we even like they give it to like a debt collecting agency. So we were kept saying like we couldn't pay, but because of my team, we were able to like file uh, send them a letter of destitution, and then with lots of evidence we provided, then they said hold the circulation, so it needs to be paid. But you know, the compassionate and to walk in the shoes of the helpless people is very important in those periods, because you know uh, all the harassment going that can make the patient depressed, and might like maybe they might survive. It's too much mentally. The pressure is very very building up with in our family, and the family separated due to the COVID situation. So I think, yeah, like, what we can learn from is more compassionate with the people who are really helpless, and like if we, I believe like we got if we build hope for people, it can be like we can build the hope for a better mankind, better future for them, so that the future generation like be more compassionate for people. So I think yeah, that's
Thank
the
you,
thing.
Rika.
Thank you.
Thank you. That's a very hopeful message, and for sure, compassion at the centre of care. That, of course, being the main theme for Refugee Week this year. So thank you so much. I've got a question for Alia as well. It's almost a double question, two sides of a coin. So I guess building on some of Chris's comments about some of those positive case studies, with your strategic hat on, Alia, what can we learn from successful campaigns that have pressured trusts to write off health bills that you might have been involved in with MO? And what would you like to see more from medical institutions, royal colleges and advocacy groups?
That is, those are two great questions. On the first one about what can we learn from sort of successful campaigns and advocacy attempts to write off health bills, I think there have certainly the sort of public awareness that's being raised around the fact that most people charged for their NHS care, the vast majority of them are the people who are least likely to be able to pay the kinds of sums of money that that the charges are. And I think sort of raising awareness on a kind of systemic level is really important, like happened in the Lewisham Greenwich Trust, where they had this inquiry and there were these recommendations that Chris mentioned, which was a really phenomenal piece of work. It was a huge piece of work that took, gathering stories and much evidence about the impact of the charging regulations in that community and under those certain hospitals. And I think certainly like that thing of speaking to people who have experience of having gone through the charging regime and having them tell their stories about what is going on is a really important part of how trusts kind of start to understand truly the impact of what they're doing, and also understanding kind of the scale of it too. So I think sort of the campaigning side of things is really, really important. There is a lot of advocacy that people can do. And I think that one of the things that is the most helpful is where health workers stand with patients who are going through this and act as, understand that health is, as Chris was saying, also this holistic thing. It's about all of these other factors, such as your immigration status and if you're being chased by a debt collector for your NHS debt. And if you have a health worker advocating for you inside that trust, where it's a very complicated system to navigate, where that person can also liaise with migrant organizations and other advocacy organizations who can do some of this work, that is so, so important. So being a kind of resource, if it's signposting, and as Rija was saying, if it's just showing some compassion and being there for a person who is going through this, I think that's unbelievably important. But I do think that sort of most powerful thing we can do is to build power in our communities to connect across sectors. So if you're a health worker in a health institution, to connect with different migrant organizations that are in your area, to connect with other campaigning groups, to connect with other health bodies, health watch groups. There are many, many others in an area where if people come together, you can sort of more powerfully gather evidence, gather stories, and support people in the community who are being charged. And what we find is trusts are always more likely to listen when there are many of you than if there's just one person. So all of those things I think are really, really important in terms of how we build power to get trust to write off. I think ultimately one of the things that we see is that we don't give up, even when trusts come back and say, but this person is chargeable. We say, well, we'll come back with a bigger petition. We'll come back with a bigger demonstration. We'll come back with more support from local politicians, with more support from local organizations, and ask again. Because at some point, trusts get really embarrassed by what they're doing also, and they realize and they recognize that what they're doing is harmful, and that the local community, whether that's staff or patient groups, see what they're doing and recognize it as harmful. And yeah, I think building power is one of the most important things that we can do. The second question, remind me please, Amran, I started writing it down and I got too excited to answer.
No problem at all, Alia. So what would you like to see more of from medical institutions such as the Royal College of Paediatrics and Child Health and other advocacy groups as part of this effort?
Absolutely. I mean, the thing to say is I think that at this point, the RCPCH is actually a beacon of light for and kind of trailblazing for other royal colleges in terms of how it approaches this. I think that both came from the pieces of research that have been done into the impact on child health. And I think that's something that we should see across different medical institutions, is really understanding the impact of the charging regulations on every sort of different aspect of the health system. You know, we sort of see it with the Royal College of Midwives and understanding how it's impacting maternity care and also their own ability to provide maternity care. That kind of research on a much wider level is something that small organizations and small campaigns like ours, well, it's not that small, but we're limited in what we can do. So I think sort of building the evidence base is really important. As I mentioned, the RCPCH has this incredible reporting tool where they're again gathering evidence around charging regulations. And I think, again, being able to do that to add to that evidence base is really powerful. But certainly things like running training sessions. We have a series of sessions that we run that can be run as grand rounds. We do a trainer session so we can teach people to run teaching sessions about the charging regulations. And we work with people to kind of embed these teachings into medical schools as well, so that it becomes part of the curriculum that everybody is taught about the need to understand how migrants and barriers to accessing healthcare work and what it is that people can do. So I think, yeah, training, more evidence, and ultimately I think helping us to advocate for the charging regulations to be scrapped, understanding the impact on communities, that this is a divisive tool, that it doesn't actually serve the NHS, it doesn't bring in more money, that all of that is ideological, much more than it is the reality. And standing with and in solidarity with migrant groups. I mean, some of the things that we've seen is also, opposition, for example, to the recent immigration bill by different medical institutions has been really, really important. And sort of being able to take those kinds of political stances feels very important, especially at this moment where it feels like migrants' rights in this country are particularly under attack. All of that is definitely needed. Everyone be more like the RCPCH, please, also.
Thanks, Alia. That's very helpful, very inspirational as well. And it's clear that there's such a wide range and diversity of activity going on. So nice to see that for people with different interests, different skills, can get involved in lots of different ways, which is super positive. I'm going to move to Chris now to just ask a question about getting involved in advocacy. So Chris, we've got a lot of junior colleagues in attendance tonight and only just a handful of consultant colleagues. So my question relates to the kind of steps that you took to get involved in advocacy, finding your voice and finding your role as a doctor in beginning to work in the interests of child health equity for some of these incredibly vulnerable children. What advice would you give to health workers concerned about the state of child health that we've talked about tonight and who are interested in getting involved but perhaps aren't sure where to start?
Right. I think one thing that gave me a very different perspective on child health, which sadly is not really part of training very much, is doing a master's degree in infectious diseases with the London School of Tropical Medicine. And this gave me a perspective of public health and global health on infectious diseases, but child health or health in general. And that gave me a lot of confidence, but also understanding, in addition to this experience of working in camps and in developing countries, to actually have that clear perspective and recognizing what is actually going wrong here. Yeah. But also knowing or have an understanding of what solutions are. Yeah. So the first recommendation really would be seek some more understanding of the wider context of global health, because what actually happens to refugee and asylum-seeking families here in the UK is global health. Yeah. And the more you know about it and the more you understand it, the better you can advocate. I really like to hear the word compassion. And I mean that it is really important to not see people as subjects, but actually feel really empathy and compassion, and have a strong view on, and I often struggle with that because many people don't like it, but I feel social justice, what it was called a few years ago, now is it called inequalities, yeah? Is a strong value for me, and develop that as a value for yourself. Yeah. So I think this would be personal starting points. When coming to advocating for patients, it is about gaining an understanding of what is happening in your area, starting with how many refugees, asylum-seeking families are there actually, how many unaccompanied minors, which we haven't mentioned yet, but it's also increasing numbers. What services are provided for them? What is their experience of living, in your community? And asking them directly, what are your difficulties here? What are you hoping for? How can I help you with that? Yeah. Beyond, treating your asthma or whatever it is. Yeah. And I think you will experience a lot of gratitude for doing that. And if you approach other organizations, including, within your own organization or council, housing organizations, they're often grateful for advice coming from a doctor. And our voice actually has weight. Yeah, that is my experience. So if I, raise an issue with a council or with social services, or if I, ask a voluntary organization for help, I feel I run into open doors, really. And I learned a lot from actually working with peoples in different sector, and from working with the families themselves as well, and getting the feedback of their experience. With regards to organizations, so I'm also a part of the ICHG, and I have to say the Royal College recently has taken, a huge turn in being very engaged in this work and doing a lot of advocacy, which, has not always been the case. I remember when I tried to get a statement about the Moria campfire a few years back, and it was a bit more difficult to convince people to do that. So I think, that could serve as a good example for other colleges as well. I don't know how much you will talk about the work of the ICHG, but I think it is worth mentioning that we are developing frameworks and tools that will help people in the future. And these things will come out not too far away, and will kind of complement and supplement the guidance which is already there on the website. Not just about what to do in an actual encounter, but also, how can you advocate at your local level? What should, standards of a service be? Yeah. At the moment, we're doing these assessments more opportunistically when these patients have contact with our service. But I think we have enough information to say, from the health needs, from their barriers, they have, that we should almost say this should be like a specialty interest, and there should be people developing that, and there should be commissioners commissioning that as a service. Yeah, in the same way we have a pediatric neurology service, there should be a pediatric refugee and asylum seeker service.
Thank you so much, Chris. It's very, very helpful. And again, reflecting on some of Alia's comments, that there's a whole range of different ways to begin to advocate and work towards meaningful and structural changes, be that within health systems and the way we go about service delivery, as well as outside of health systems, be that the advocacy in the community and working in collaboration with schools, primary care, and so on. Thank you for that, Chris. We've got about 6 or 7 minutes left for questions from the audience, and I've had a few come through the Zoom chat already. I can see we've got a hand up from one of our attendees. I'm just going to end the recording.